So we are starting this session from Oral Lichen Planus Therapeutic Guidelines, page number 101. Lichen planus is one of the commonest oral mucosal lesion in terms of when we are diagnosing cases or lichenoid reactions, to be more precise. Now, lichen planus they have written, is an uncommon idiopathic immune-mediated condition that can affect skin, hair, nails, and oral and genital mucosae. Oral lichen planus, typically it is idiopathic. One does not know the much of etiology or immunogenesis of it. It is immune-mediated. Oral lichen planus typically occurs on the buccal mucosa, tongue, and gingiva. In the non-erosive form of the disease, the lesions consist of a characteristic reticular pattern of white striations or plaques. Erosive oral lichen planus presents as erythematous, ulcerated, or eroded areas of mucosa, which are often painful. Symptoms include stinging or burning, especially with spicy or acidic food. So, basically, the areas involved are buccal mucosa, tongue, and gingiva. In non-erosive form, lesions consist of characteristic reticular pattern, that white striations like a web would be there, or plaques can be seen. And erosive one, where the mucosa breaks up, it becomes erythematous. It can become ulcerated or eroded areas of the mucosa. The name itself says erosions has occurred, which are often painful. Symptoms include stinging or burning, especially with spicy or acidic food. Oral lichen planus is associated with an increased risk of oral squamous cell carcinoma. Then oral lichen planus is associated with an increased risk of squamous cell carcinoma. It's a pre-malignant condition again. Here the word is condition, and again highlighting another word from it is a lesion. Okay, the HPV is a lesion. Leukoplakia and erythroplakia are pre-malignant lesions. Okay, when we see oral leukoplakia, it is a lesion which is pre-malignant. Explicitly here, it is not written lesion per se. Okay, non-removable white lesion per se, it is written over here. And in erythroplakia, if you see, it is clearly written fiery red lesion. And here they always talk about it's a pre-malignant lesion, potentially malignant, pre-malignant. In papilloma also it is mentioned of word lesion. But when we talk about lichen planus, it's a condition. So this difference you need to memorize and be mindful of it. Now, refer patients with suspected oral lichen planus to a specialist for biopsy. So biopsy is needed. Referral to specialist with biopsy is needed. Definitive diagnosis after doing the biopsy, they would do the definitive diagnosis and management. Differential diagnosis should exclude oral lichenoid lesions. If lichen planus occurs on gingival tissues, management includes improving oral hygiene and periodontal health. Patients with oral lichen planus require ongoing review by the oral medicine specialist, who is the specialist here, oral medicine, because of the chronic nature of the condition and potential for malignant transformation. If biopsy proven oral lichen planus becomes symptomatic, treat with betamethasone dipropionate 0.05% cream or ointment topically to the lesions, twist twice daily after meals until symptoms resolve. So we are using, what is betamethasone? It's a corticosteroid. Cream or ointment is used to treat this, resolve the symptoms. Because it is immune mediated, we need to dampen the immunity for it to heal. The cells are, immune cells are producing mucosal disruption here. Advise patients to stop using topical corticosteroids once symptoms have resolved. If the patient's symptoms have not improved after 3 weeks of, not improved even after 3 weeks of the topical corticosteroids, symptoms change or the appearance or texture of the lesion changes, advise patients to return to their treating specialist. Oral lichen planus of the left buccal mucosa showing characteristic white lesions. White striations. This is like the reticular pattern white striations here. This is oral lichenoid lesion due to contact hypersensitivity to an amalgam filling. So lichenoid and lichen planus, what is the difference? In lichen planus, it's idiopathic. We do not know the cause. But in lichenoid lesion, there is always a cause present which we can associate with. So here it was amalgam filling and hypersensitivity to this. Then we have oral lichenoid lesions. They are similar in appearance to idiopathic oral lichen planus, but the difference in the etiologic factors. Lichenoid mucosal reactions can be caused by contact hypersensitivity to dental restorations, hypersensitivity reactions to drugs. Patient history will tell you both, and clinical examination and history will tell you about restorations. So which are the drugs which can lead to lichenoid reaction? Drugs that lower BP in high BP patients, which are beta blockers, angiotensin converting enzyme inhibitors, diuretics, particularly hydrochlorothiazide. So these are important range of drugs you should associate if you find any lesion that it could be associated to lichenoid lesion, and it could be because of these drugs which produce lower blood pressure. Then we have NSAIDs, non-steroidal anti-inflammatory drugs, and drugs that treat thyroid disorders. Medical conditions, hepatitis C infection, particularly in patients with human leukocyte antigen, HLA-DR6 allele, which is common in people of Mediterranean descent. Thyroid disorders, chronic graft versus host disease. Refer patients with a suspected oral lichenoid lesion to an appropriate specialist for definitive diagnosis and management. In the case of contact hypersensitivity to amalgam filling, replacement of the implicated amalgam filling may result in partial or full resolution of the lesion. However, removal of all amalgam fillings is not recommended. So you can replace the implicated amalgam filling. So if the lesion was in, suppose, opposite to 4-6, which was amalgam filled, and the patient has many other amalgam fillings like 3-6, 2-6, 1-4, 2-4, it is not recommended to replace all the amalgam fillings for composite because he had one area, one stretch of contact lichen planus, lichenoid reaction, sorry. Only removal of all amalgam fillings is not recommended. It's an important point. When it comes in MCQ, one can get confused and choose answer as all amalgam fillings should be removed. However, clearly written here, implicated amalgam filling only and not all. The next lesion is geographic tongue. Geographic tongue erythema migrans is a benign condition affecting up to 5% of the population. It manifests as a migratory red lesions and usually involves the dorsal surface of the tongue, but sometimes extend to the floor of the mouth and the buccal mucosa. The red patches have a central atrophic and depapillated zone. So 5% of the population, migratory red lesions, which keeps moving different places on the tongue surface, dorsal surface of the tongue. But sometimes extend to even, it can extend to floor of the mouth and buccal mucosa also. Red patches have a central area of deep papillation where papilla have been lost. That's why it is looking more red, which is the common presentation and is surrounded by elevated white or cream margins. So white borders inside red. Occasionally, central red patch is sensitive but not painful. If pain or burning is present, investigate other causes or seek specialist advice. The causes of geographic tongue is unknown, but there may be a family history of the condition. Some patients have atopic allergies or can relate the lesions to particular foods or stress. Histologically, the lesions are psoriaform, psoriasiform, which is implication of or similar to, analogous to psoriasis of skin. But geographic tongue is not related to specific condition. Psoriasis, where the skin peels off in, this blisters kind are created, the skin gets desquamation of the skin happens. So histologically, they are psoriasiform, but geographic tongue is not related to psoriasis per se. Management of geographic tongue is not required. It is self-healing or a self-limiting kind of a disease beyond correct diagnosis and reassurance. If any red flag features or oral mucosal disease are present, then you refer to appropriate specialist. This is how the geographic tongue looks like. And I have even seen geographic tongue in a child less than 3 years of age also. So it can be present and nothing much. Vitamin B supplementation can be given to these patients, just that. No treatment per se is required. Then we have amalgam tattoo. Amalgam tattoos are the common cause of exogenous oral discoloration. They result from iatrogenic mucosal implantation. Iatrogenic means dentist, professional induced something. Mucosal implantation of amalgam particles during the course of a dental procedure. They are usually small, macular, blue-gray to black in color. Amalgam tattoos are usually found in close proximity to amalgam restored teeth where such teeth were previously present, or if they were previously present. Even if the restoration is redone, rechanged to composite, or if the tooth is removed, amalgam tattoos can be usually found in there. Amalgam tattoos are benign and do not require treatment beyond correct diagnosis. To confirm the diagnosis, metallic amalgam particles may be evident on X-ray. If the diagnosis is not confirmed, or if any red flag features or oral mucosal disease are present, refer patients to an appropriate specialist. Then we have, this is how the amalgam tattoo looks like. It gets embedded and looks like a discolored skin patch. But the classic diagnosis would be based on, it doesn't come naturally from birth. It happens after impregnation of the mucosa with amalgam particles, means after the filling has been done. Then comes hairy tongue. Hairy tongue occurs when excessively long and keratinized, hyperkeratinized filiform papillae of the tongue become stained by an accumulation of epithelial cells, exogenous material, or chromogenic microorganisms. It is usually black, but may be other colors and can occur with the use of chlorhexidine mouthwash. Okay, so hairy tongue can happen with chlorhexidine mouthwash. You remember it stains the teeth also, but it stains, it can produce hairy tongue also because of it changes the normal commensal bacteria of the oral cavity. And it can occur after a course of antibiotics or in patients who have limited oral intake. Example, percutaneous endoscopic gastrostomy feeding, which is nasal tube or tubes, which is feeding the gut without oral chewing forces. If any red flag features of, because salivation is not happening, flushing of the oral cavity is not happening as a usual regular case of oral flushing usually happens. If any red flag features of the oral mucosal disease are present, the box read before, refer to appropriate specialist. Red flag features, referral to specialists. Management of the hairy tongue primarily involves identifying and addressing the cause. Other strategies include improving oral hygiene. So it is like something like candidiasis. Address the basic cause of it. Oral hygiene, brushing the tongue also gently with a toothbrush and using sodium bicarbonate, which is a basic mouthwash. Sodium bicarbonate mouthwash can be made at home by adding a teaspoon of sodium bicarbonate. Now you would ask, where is sodium bicarbonate available? It's the baking soda in the regular homes, to a glass of warm water. And the mouthwash can be rinsed in the mouth or waking and at any time during the day. So just a half a teaspoon of this sodium bicarbonate in glass of warm water, swish it on waking, any other time during the day. It should be helpful in treating the hairy tongue, and mild scraping of maintaining the oral hygiene. Next, we have traumatic oral ulcers. Oral ulceration due to trauma is common and can be associated with eating rough, sharp, or hot foods, sharp broken teeth or dental restorations, toothbrushing, oral prosthesis or orthodontic appliances, chemical burns. So any of these things can lead to the trauma which produces an ulcer. It is common type of an ulcer. Address causes of the trauma. Say if an orthodontic wire is broken in the mouth and it is piercing and causing ulcer, address the cause of trauma, including changing oral hygiene practices, smoothing sharp edges of teeth or restoration, adjusting prosthesis, or placing wax on orthodontic appliances. Most traumatic ulcers resolve spontaneously if the cause of the trauma have been adequately addressed. However, if any red flag features are present, if even after correcting the, if it is addressed, suppose you have repaired the restoration which was irritating there, and even after 2 weeks the patient comes back with the ulcer not resolving, that's a red flag feature. So then you would send this patient for biopsy. A salt water mouthwash is antiseptic and may provide symptomatic relief. If temporary pain relief is needed, we can provide topical anesthetic or analgesic to the ulcer, such as benzidamine 1% gel. Adult and child 6 years or older, topically to the ulcer 2 to 3 hourly as necessary. Persistent ulcer lasting more than 2 weeks. Despite addressing the cause of trauma, it's a very important line in here. Make a note, mental note of it. Or recurrent ulcers require investigation, refer to appropriate specialist. Highly important. So if a patient comes to you with a traumatic ulcer, you diagnose it as because of a traumatic tooth, a broken tooth or a broken filling, it is creating a ruggedness, friction, and this ulcer is happening. You treat that tooth, you remove that tooth, or you redo the restoration and call the patient to again for 2 weeks. So you have addressed the cause and it is still persisting for more than 2 weeks, even after addressing. Then referral for biopsy must be done. It could be something sinister. Next is recurrent aphthous ulcerative disease. A recurrent aphthous ulcerative disease is the most common cause of non-traumatic ulcers of the oral mucosa. So most common cause of non-traumatic ulcers of oral mucosa is aphthous ulcers. Now that also refers to us that most common cause of ulcers of the oral mucosa is traumatic ulcer. Okay. Recurrent aphthous is most common cause of non-traumatic ulcers of oral mucosa, but the most common cause of ulcers is traumatic ulcers. The disease has immune-mediated pathogenesis. Recurrent aphthous is immune-mediated. It doesn't happen by trauma, or it's always immune cells are lysing the healthy barrier, which is mucosa, and is characterized by periodic eruption of the painful ulceration of oral mucosa. Aphthous ulcers can occur acutely with smoking cessation. Okay. Sometimes you take the history for aphthous ulcers. The patient says that I was fine. The moment just a week back, I quitted smoking or reduced. I'm on quitting smoking journey, and I'm getting these ulcers. So, but you have to be motivate these patients. They should resolve with time or can be triggered by trauma, toothbrushing, orthodontic appliances to address causes of the oral trauma. So aphthous ulcers, why in quitting it happens? Because there is a that friability of the mucosa. Because of the smoke, the nicotine, the mucosa was a bit tough. When it is suddenly quit or reduced the smoking, then the mucosa becomes a bit more friable and ulcers happen. The ulcers usually occur on mucosa of the cheek, lip, and floor of the mouth. This is aphthous ulcers, usually happen on cheek, lip, floor of the mouth, but can occasionally be affecting a mucosa of the gingiva and the hard palate. Usually seen on the mobile mucosa, what we can move. Okay, cheek, lips, and floor, we can move about. Hard palate and gingiva cannot be moved, so it less commonly here. Now we have three forms of aphthous ulcers are recognized. One is minor aphthous, then we have major aphthous, and last is herpetiform aphthous ulcers. Okay, so most common form, minor aphthous, they have the smaller lesions 2 to 4 millimeter in diameter. They occur few at a time and heal within 7 to 10 days. So this is the common presentation. Small, tiny 2 to 4 millimeter ulcers can happen. A few can happen over a time and heal within 7 to 10 days. Then we have the major aphthous, is the less common form. Present as larger lesions, which is 10 millimeter or more. Can persist for up to 6 weeks. Large in size, longer in duration, and occasionally months also, and heal with submucosal scarring. So scarring happens when the major aphthous ulcer happen. Then we have herpetiform aphthous ulceration, which is rare. It presents as recurrent crops of non-vesicular small ulcers, 1 to 2 millimeter in diameter, that coalesce to form larger ulcers. Heal within 1 to 2 weeks and not caused by the herpes virus, so do not have a cluster pattern. So recurrent crops of non-vesicular small ulcers, 1 to 2 millimeter in diameter, which coalesce to form larger ulcers. Heal within 1 to 2 weeks, not caused by herpes virus, so do not have a cluster pattern. It is herpetiform and not herpes per se. Assessment of aphthous ulcers involves taking a thorough history and examination. Also, we need to check the red flag features of the oral mucosal disease. In children, investigate for systemic causes of non-traumatic ulceration. In addition, in adults who have additional symptoms, like investigate for a systemic cause. Systemic causes of aphthous ulcers include iron, vitamin B12, folate, or zinc deficiency, celiac disease, ulcerative colitis, Beckett syndrome, and PFA-PA, which is periodic fever, aphthous stomatitis, pharyngitis, cervical adenitis syndrome in children. So systemic causes of aphthous are vitamin and nutritional deficiencies, basically, celiac disease, gut disease of absorption, ulcerative colitis, Beckett syndrome, and PFA-PA. Deficiencies should be treated only on laboratory confirmation. This is how the mandibular mucosa, labial mucosa, minor aphthous looks like. Now, management of the recurrent aphthous ulcerative disease. If an aphthay-like ulcer occurs in a child, refer for further investigation because it could be a sign of systemic disease. For the management of aphthous ulcers in patients receiving palliative care, we would see separately. Topical corticosteroid treatment can produce rapid healing of the minor aphthous ulcers. Particularly if used in prodromal or pre-ulcerative stage, the aim is to treat the lesion rather than prevent further outbreaks for adults. For example, use hydrocortisone 1% cream or ointment topically to the lesions 2 to 3 times daily after meals. So this is, we are using corticosteroid 1% cream. If pain relief is required for minor aphthous ulcers, apply topical anesthetic or analgesic, which is benzidamine 1% gel 2 to 3 hourly as necessary. So this is for treatment, rapid healing of minor aphthous, especially in pre-ulcerative stage. So what does it mean by even pre-ulcerative stage we apply this? Aim is to treat the lesion rather than prevent further outbreaks. Then we have lidocaine viscous solution is an alternative option to benzidamine for hospital settings. But this needs higher cost for adults. Use lidocaine 2% viscous solution. Use the lowest dose necessary up to 15 ml. Rinsed in the mouth for 30 seconds, then spat out. 3 hourly as necessary, and maximum 8 doses in 24 hours. Ulcers that are not improving after 2 weeks are potentially malignant and refer to a specialist for management and biopsy. Seek specialist advice for patients with major or herpetiform aphthous ulceration or immunocompromised patients with neutropenic ulceration. So for major herpetiform ulcers, which heal with scarring or which repeat itself, which are more than 10 millimeter in diameters, herpetiform is when it happens in crops of ulcers, specialist advice is needed. Or in immunocompromised patients with neutropenia, where the neutrophils are less. Then we have the next disease, which is oral mucocutaneous herpes. Now, primary oral mucocutaneous herpes, it is herpetic gingivostomatitis, which is the primary HSV infection, occurs in childhood with fever, painful intraoral lesions, systemic symptoms like malaise, lethargy, and cervical lymphadenopathy. Intraoral herpes simplex lesions begin as blisters and ulcerate rapidly. Healing occurs within several days in infants, but can take up to 2 weeks in older children. So this is a viral condition. It heals by itself because when the immunity is gained, the viral path of first infection is over, it heals usually. During this time, it may be difficult to treat. It comes as a very massive, gory, presentation of multiple ulcers in the oral cavity. And the name itself says it is gingivostomatitis, not just the gingiva, whole of the oral cavity is having these ulcers. It is difficult to eat, drink. Hospital admission may be required because the child may dehydrate. Herpetic gingival stomatitis is rare in adults but can be severe and present with dehydration due to severe odynophagia. There is painful eating. While herpes simplex virus is most common virus to cause mouth ulcers, it is most common virus to cause mouth ulcers. It is not the most common ulcers. Okay. Other viruses, which are varicella zoster virus, Coxsackie virus, cytomegalovirus, also may be the cause. So HSV is the commonest virus, but these are other viruses which may be the cause. Intraoral herpes simplex virus may resemble those seen in the necrotizing gingivitis. We would read necrotizing gingivitis later, but it is rare in children. It's seen more in the adult males, young adults or middle-aged adults with at least a history of smoking. And it would have punched out ulcers with a putrid smell, and a grayish slough pseudomembrane would be there in necrotizing. Necrotizing, the word itself means dying gingiva. So you would find those features in there. And it is also correlated to decreased immunity. For some manner, you would find that. And necrotizing gingivitis would be specifically seen in gingival tissue, especially the papilla would be having punched out ulcers. While herpetic gingival stomatitis lesions are widespread and cover all soft tissues in the mouth, like the whole mouth would be having these lesions, not just the gingiva. Here it is the palate lesions. To reduce the risk of virus transmission, advise patients with an active herpes simplex virus to avoid direct contact of the lesion with other people. To reduce the risk of virus transmission, we advise patients with active herpes simplex infection to avoid direct contact of the lesion with other people. Treat minor primary oral mucocutaneous herpes with supportive management, like it is important to rehydrate the patient with oral fluids, antipyretic drugs, and analgesia. Apply a topical anesthetic or analgesic like benzidamine 1% gel topically to the lesions 2 to 3 hourly as necessary. If this is not available, lidocaine viscous solution is an alternative topical anesthetic for hospital settings. Lidocaine 2% viscous solution, adult use the lowest dose necessary for up to 15 ml. It is rinsed in mouth for 30 seconds, then spat out 3 hourly as necessary, and maximum 8 doses in 24 hours. Child 3 years or older, use the lowest dose necessary up to 0.2 milliliter per kg, which is rinsed in mouth for 30 seconds, then spat out. It is 3 hourly as necessary, maximum 4 doses in 24 hours. Child younger than 3 years, use the lowest dose necessary up to 0.2 ml per kg. Apply to the affected areas with a cotton swab 3 hourly as necessary, maximum 4 doses in 24 hours. So lidocaine 2% viscous solution is the relieving agent. We have to use the lowest dose. Adult up to 15 ml, child 0.2 ml per kg, child younger than 3 years, again 0.2 ml per kg. Maximum here is 5 ml, maximum here is 1.25 ml. Here we will use swab in a child less than 3 years. Okay, cotton swab and spat it out. If the pharynx is affected in adults and children older than 12 years, lidocaine viscous solution can be gargled and swallowed for the pharynx. So take it in, swallow it. Primary management of primary oral mucocutaneous herpes differs for the following patients, so referral to a medical practitioner is required. Patients with severe presentations, immunocompromised patients, and patients with HIV. Here, very severe ones, immunocompromised, again HIV is again a form of immunocompromise, needs a referral to medical practitioner. We would begin with recurrent oral mucocutaneous herpes in the next session. Thank you.